Hi, I'm Jeff Ponsky. I'm a general surgeon at the Cleveland Clinic in Cleveland, Ohio. And today we're going to talk about the topic of cholecystitis.
What causes cholecystitis?
So cholecystitis is a type of disease which I like to call an obstructive diverticulopathy, much like appendicitis or diverticulitis of the colon. Here we have blind pouches with narrow outlets which can get obstructed. Should this outlet, in this case of the gallbladder, the cystic duct, become obstructed by a stone or a mucus plug, then the contents of the gallbladder tend to increase due to secretion. The arterial blood continues to come in at 120 millimeters of mercury, but the venous outflow, which is only about 7 or 8 millimeters of mercury, is soon overcome. The arterial inflow continues, and you have trapping of blood within the wall of the gallbladder. Now, early on in this process, if the stone falls away, we get a situation called biliary colic. The patient can have attacks of this pain, which are very intense, and the stone falls away, and the patient becomes asymptomatic once again. And this can continue to go on and on, with the patient having multiple episodes of pain. Over time, the gallbladder with this can still become thickened and shrunken and will need to be removed to ameliorate these symptoms. So, if the patient has a progression of the disease without relief of the obstruction, the gallbladder may undergo ischemia. Then we get pericholecystic fluid and empyema and a subhepatic abscess. So what we've learned from this is that when a patient comes in with acute cholecystitis, we have to act definitively and quickly.
So, Dr. Ponsky, are there any situations where you can get cholecystitis and not have gallstones?
Yes, so the gallbladder typically becomes obstructed by a stone or a mucus plug. However, in some conditions, particularly when the patient hasn't been eating for a long time or the patient is critically ill, we find that the patient's gallbladder becomes atonic. It continues to have fluid secreted and it doesn't empty well. The patient comes in with pain, sometimes fever and tenderness, and we get an ultrasound and see, to our surprise, no stones. We call this acalculous cholecystitis.
What are the risk factors for cholecystitis?
Certainly, we've always made the joke that patients who were likely to get gallstones were fair, fat, 40, and fertile. It's more complicated than that. I think any race, any ethnic group can certainly get cholecystitis and gallstones. And it's interesting that there are some genetic predispositions. Southwestern Indians, patients in South America often have a high incidence of gallstones. Patients with hemolytic diseases such as sickle cell anemia or spherocytosis can get bile salt stones. You can get patients who've had rapid weight loss, such as patients who've been on diets, or patients who've had weight loss surgery can get stones with an increased frequency.
How would you expect a patient with cholecystitis to present?
In the area of biliary colic, the patient typically will present with right upper quadrant pain and nausea and often vomiting about 20 minutes to 2 hours after eating. This is because cholecystokinin is secreted from the duodenal mucosa in response to fat in the duodenum. This causes the gallbladder to contract. And then if the gallstone gets stuck in the cystic duct, they get this terrible right upper quadrant pain. Again, if this is not relieved, then this goes on to the sequence I previously described, where the gallbladder becomes inflamed and the patient now develops not just colicky pain, but constant pain, even with local peritonitis, fever, and sometimes they can have associated jaundice, which often means there can be a complication.
What other diseases belong on the differential diagnosis with cholecystitis?
Well, it's important as a surgeon we jump to cholecystitis because that's what we're most familiar with. It's certainly the most common thing we see, but we have to, as a physician, stand back, take a deep breath, and think of other potential causes which might not require surgery. For example, pancreatitis is always something to think of with right upper quadrant pain, and peptic ulcer disease, hepatitis, a drug reaction, leptospirosis or something like that. So always think of the zebras and other things that could go on, and that will make you get some laboratory tests which will help make sure you get the right diagnosis.
How do you evaluate a patient with cholecystitis?
So it's always important, in addition to doing an excellent history and making yourself talk about drugs they might be taking, normal medicine they might be taking, any allergies, any exposures they've had. But aside from that, you do a good history, and then you look at the physical and you examine the patient carefully, looking at their abdomen. If you find in the right upper quadrant that they have a positive Murphy sign, which is tenderness with a deep breath in the right upper quadrant that stops their breath, that's very elucidating, and it may suggest cholecystitis. It can be present in other conditions. Again, pancreatitis can mimic this too.
So if we have a physical exam that suggests pancreatitis or hepatitis or cholecystitis, what type of lab work should we be getting?
Get routine CBC and DIF. You want to get electrolytes. I certainly want liver function tests, which will both show me the transaminases, which might be elevated out of proportion in hepatocellular disease, as opposed to the alkaline phosphatase and GGT, which might be elevated out of proportion in biliary ductal obstruction. So you want to look at that. You want to look at the bilirubin, direct and indirect, and dissect out exactly what's going on. Sometimes you're surprised by your laboratory work. For example, in a patient with hemolytic anemia, you see an indirect hyperbilirubinemia, which you really didn't expect in typical gallstones. So it may elucidate your course of action. But if you see them in your office, obviously, you're going to say to these patients, I want you to get a right upper quadrant ultrasound. Now, it's interesting. We use CT scans so often here. Everyone jumps to a CT scan. I really like the right upper quadrant ultrasound better for the initial diagnosis of cholecystitis and biliary colic, because it shows you the anatomy of the gallbladder. It shows you the wall thickness of the gallbladder. It shows you whether there's pericholocystic fluid, and it shows you the stones in the gallbladder. It can also show you the diameter of the common bile duct, which should be less than 7 or 8 millimeters, and whether there might be stones in that common bile duct. Where you sometimes would like to get a CT scan is if you find that you suspect pancreatitis is playing a role in here or an accompaniment to this. A CT scan, when there's any question about the pancreas, is better than the ultrasound.
Say we have blood work that shows elevated AST, ALT, and a slightly elevated bilirubin. When would you use an MRCP or ERCP?
You're talking to someone who does ERCP for his career, and I would love to do every patient you find. But I think it's important that we outline the correct and most appropriate use of these advanced imaging techniques. First of all, if the patient comes in with only minimal bilirubin elevation, I would say less than 2. Usually no concern for doing an ERCP, no reason to do the ERCP. And even if they have acute pancreatitis when they come in, I would wait to do an ERCP. If they get better in the first day or so, I would not do the ERCP. Studies have shown that 2/3 of these patients, when you do it, have a normal duct because they pass the little stone. When they get their pancreatitis, they don't need it. So what I do is if the patient comes in with real jaundice, with a bilirubin, say, of 4 or higher, and it's not improving, then I would get an ERCP. Because there are other things like ampullary tumors and ductal problems and pancreatic things that could cause an elevated bilirubin. And I don't take a patient with real or deep jaundice to the operating room for a gallbladder operation without an advanced biliary imaging like an ERCP or an MRCP, period. But if the patient comes in with minimal elevation of their bilirubin, with their amylase and lipase reasonably normal, I would say you don't have to do an ERCP or an MRCP. You could take them to the operating room as soon as they're stabilized, perform your laparoscopic cholecystectomy, and plan to do a cholangiogram. If there's any question of an elevated bilirubin or abnormal liver functions, if there's any question of a dilated duct on ultrasound, if there's any question of recent pancreatitis, those patients should have an intraoperative cholangiogram. That's called selective cholangiography. There are some people who do routine cholangiography because they look for abnormalities in anatomy and they look for occult stones.
So If a patient comes in with episodic right upper quadrant pain, they had blood work that shows no leukocytosis, they previously had ultrasound that's negative for stones or cholecystitis, what do you do next?
Well, this is the challenging one, see. So these patients come in and you know the diagnosis. You've got cholecystitis, for Christ's sake. Let me take out your gallbladder. And you get the ultrasound is normal. So you scratch your head a little bit. You say, you know what? I'm certainly going to do some other tests. One test that you mentioned is looking for peptic ulcer disease might be an upper endoscopy. And that's perfectly appropriate. You've already gotten the pancreatic information and that's okay. And if it's not clear, you might even do a CT scan of the abdomen looking for some abnormality of the pancreas. But most of the time, that's all going to be negative. And so now what do you do? Well, we've talked about ultrasound, and what that shows us is anatomy and structure of the gallbladder. But it doesn't tell us about function of the gallbladder. And so what we do then is a HIDA scan, and we look for filling of the gallbladder. Now, if the gallbladder does not fill, then we have presumptive evidence of cystic duct obstruction, and we say, oh, they've got a positive HIDA, the gallbladder doesn't fill, and therefore they have acalculous cholecystitis. But guess what? Some of those patients will still fill the gallbladder. So now you shake your head again. Okay, I filled the gallbladder. They can't have acalculous cholecystitis, but they can. And it may not be due to cystic duct obstruction, but functional loss of integrity of the gallbladder. So what do you do in them? You give these patients CCK, cholecystokinin, either IV or you give them a fatty meal. This is called CCK cholecystography. And you look for squeezing of the gallbladder on the HIDA scan. If the gallbladder is normal, it will have an ejection fraction over 35%. But if the ejection fraction of the gallbladder is less than 35%, then they have an abnormal motility of the gallbladder, and many people would take out the gallbladder in a symptomatic patient like this. That is called biliary dyskinesia.
Once we have lab work and imaging consistent with cholecystitis, how do you manage the patient?
Years ago, we believed that the right thing to do for acute cholecystitis was to put the patient in bed rest, NPO, IV antibiotics. So we'd send them home after they got better and take out the gallbladder in 6 weeks because we believed that that led to less difficult dissection. What we found is a lot of these patients came back within that 6 weeks with another acute attack. And so now we believe that after the patient is stabilized, that we should go on to surgery, hopefully within that hospitalization. Now, there are reasons where you'd still employ program of waiting. If a patient comes in, they've had a recent MI, they're very unstable and they have acute cholecystitis, we could do a percutaneous transhepatic cholecystostomy to vent the gallbladder, take out the infected bile, and do them in months to come when they're better and lower risk.
When we're treating these patients initially with antibiotics, are there certain bugs we should be worried about or certain antibiotics we should be using?
Well, I'm never as up to date as my residents on what the latest antibiotic is, but you want to cover for E. coli, Enterococcus, Klebsiella, and Enterobacter. And you can check on what the latest, greatest stuff for that is.
According to SCORE, it's cephalosporins and fluoroquinolone, so I'm going to go with that one.
Good.
What anatomical variations should you keep in mind when operating on a patient for cholecystitis?
So the gallbladder, you know, we all think it's so simple. How hard could it be? It's a blind diverticulum. It looks like a child's balloon, doesn't it? And the top of the gallbladder, where we see it up on the liver, is called the fundus. And then it narrows down a little bit, and we call that the neck. And then there's this little pouch right above the cystic duct where we always grab it when we operate to retract it, and that's called the infundibulum. Often there's a stone sitting in that spot. Then we go down to the cystic duct, which can be very long, or sometimes in difficult situations, that cystic duct can be very short. And although we think the cystic duct enters into the common duct, and it can sometimes have aberrant entries. It may enter in, for example, the right hepatic duct or an accessory right hepatic duct. And sometimes the cystic duct can go parallel with the common duct in a common sheath all the way down to the papilla of Vater. The gallbladder is an organ that is waiting for you to make a mistake. You have to always assume, even if it's the easiest case you ever did, always assume that it's ready to get you, because it is. You can have a double gallbladder. You can have a totally intrahepatic gallbladder. The cystic artery, which typically forms part of Callot's triangle, can flip over the cystic duct in some patients. And so you constantly have to be looking for the correct anatomy and identify all that anatomy before you divide anything.
What are the key steps to a laparoscopic cholecystectomy?
Without going into too much detail, we do a laparoscopic approach. We start usually at the umbilical port and put in our first trocar. And then we put in an epigastric trocar, a right upper quadrant trocar, and then a right lateral trocar. We grab the fundus of the gallbladder and elevate it upward. And you want to strive to pull that infundibulum away from the midline so that you start to see the common duct area, and you start to get some length on the area where you think the cystic duct is. Taking all the loose areolar tissue, teasing it off the area of the cystic duct. We do the same thing in the area of the cystic artery, and you will identify what we call Callot's triangle, which is bordered by the cystic duct below and the cystic artery above. And here's where you don't rush. You want to make that cystic duct long. You want to keep rubbing it gently, bluntly, to get length on it. You want to get that artery so that you get some length on it. Then I like to take the peritoneum of the gallbladder, and a lot of people take this peritoneum up about an inch or so or even longer before they do any division of any ducts, because they want to see the back wall of the gallbladder and take it off the liver bed before they do any dissection of the ducts. It's very important that we look at this, we take a deep breath, and you say to everybody else in the operating room, does everyone agree? We see the critical view of safety, we see the cystic duct, we see the cystic artery, we can see where the common duct is. And then once you do that, you can dissect underneath that cystic duct. And I'd like to put my first clip as high on that cystic duct against the gallbladder as I can. And then if I'm going to do a cholangiogram, I go 1 millimeter or 2 proximal toward the common duct and cut into the duct partially and put a cholangiogram catheter in and get a cholangiogram. Assuming that you're done with the cholangiogram, you put on your second clip below your ductotomy, but again, making sure you're far away from the common duct. And then I divide between them, lift up the gallbladder further, dissect out the artery. I put my first clip on the business side of the artery. I put 2 clips there, and then I put one up top by the gallbladder and divide that. Then take the peritoneum up both sides, and with your hook or whatever you use, you take every little fiber and take it off. When you're done taking it off, you look at the gallbladder bed carefully. Don't be in a rush to get out. Sometimes you will see a little spot of bile. That could be a duct of Luschka. You look for any little bleeders. You can buzz those or even put a little stitch them. It's a good idea then to take the gallbladder out, but then while the abdomen's deflated, you go back in again and look at that bed, because sometimes the pressure of your pneumoperitoneum can stop bleeding. And so you want to let it bleed if it's going to bleed, so you can look at that bed once again before you quit. And then you close your trocar sites and you're done.
When should you consider converting to open?
When we do this, if you find that there's dense adhesions, unclear anatomy, unplanned bleeding, you're not making progress at all, you say to everybody, guys, before we get in trouble here, we're going to re-prep a little bit, we're going to make an incision in the upper abdomen, and we're going to go in and do this open. Converting to open is a decision that you make in the management of a disease, and it's not a failure, it's an option. And another thing which is extremely important in these tough cases, if you have an associate or a friend who can come in and work with you on this, this is not an embarrassment. This is a tough case. So make sure that you're careful.
Once you've had a successful cholecystectomy, what complications should you keep an eye out for post-operatively?
The patient goes to recovery room, and many of these patients are intended to go home within a few hours. You watch them in recovery room. Do they have tachycardia? Are they hypotensive? Are they requiring pushes of fluid? That's not normal. And that may indicate an acute bleed or a cystic artery that's got in the way, and you should go right back to the operating room. Barring that, and if everything goes well, the great preponderance of patients you don't hear from. And then if you get called by the emergency department because 3 days later or 2 days later, that patient is there with right upper quadrant pain, you should assume there's a complication. And most often it could be a bile leak. And for those patients, some people like to get a HIDA scan. Some people like to get an ultrasound to look for a pericholecystic fluid, but there's often fluid after a gallbladder in the first few days. My approach was to get a CT scan. And if the CT scan showed a lot of fluid in the gallbladder fossa, I would have the radiologist just tap it and see if it was bile. If it was bile, I had them put in a pigtail catheter, and then we would plan to go right to ERCP. Right then, my heart is beating fast because I'm worrying that I might have injured the common bile duct and praying that it's just a cystic duct leak or a duct of Luschka. We do the ERCP and we see what we show. If we show the whole common duct in normal continuity, we take a deep breath and smile, and we do a biliary stent. A biliary stent lowers the pressure in the normal direction to 0, and now within a day or two, that fluid collection will be drained out of your percutaneous drain. All the bile will come through the normal direction. Your percutaneous drain will stop draining, and your patient will be well, and in 6 weeks, I pull out the stent. On the other hand, if there is a bile duct injury, if it's an incomplete injury, we may have to stent it. If it's a complete injury, well, then you have to plan for more definitive surgery. This isn't something you ignore. This is something you go after. Attack, attack, attack. So some other things that can occur in the postoperative period that usually aren't that acute. If the patient presents a little later with pain and perhaps even jaundice, you might get an ultrasound at that time and see a dilated duct, or you might just go right to an ERCP, and that ERCP may show that you missed a stone that's in the common bile duct, and those can be taken out usually very easily with a 95% success rate. I will say that every now and again you find an abscess in the belly due to a stone, and those sometimes require a laparoscopic exploration and irrigation, and I've even seen them require open surgery to take out the infected stone. So try to keep the gallbladder intact. If there is an injury, get your sucker right in there, take the stones out and collect them. Now that we've discussed cholecystitis, I'd like you, the audience, to think about what your key takeaways are for the management of cholecystitis and how you would take care of a patient with this condition. I think that the surgeon taking care of a patient with possible cholecystitis has to be aware of the potential other diagnoses which can be present. He has to be aware that cholecystitis is an obstructive diverticulopathy, which can have horrible outcomes if not attended to quickly. You have to know the difference between acute cholecystitis and biliary colic. And then we have to know how to proceed with the workup of cholecystitis. And then, of course, when to operate. I think it's important to know that a patient with a cholecystitis should not leave the hospital until they have their operation performed.
That's a wrap on cholecystitis. Be sure to let us know what questions and thoughts you might have. This videocast was created and edited by Rae Hanke, Zach Korb, Todd Ponsky, and Jeffrey Ponsky.